In cardiology, CRT stands for cardiac resynchronization therapy. That's a type of pacemaker with three leads, one in the right atrial appendage, one in the right ventricular apex, and another in the left ventricular epicardial region. The lead goes through the coronary sinus into a posterior left ventricular branch, so that it is almost pacing the left ventricle from the epicardial region. That produces synchrony of left ventricular contractions and is useful in heart failure with reduced ejection fraction. This is a more advanced device which is cardiac resynchronization therapy with a defibrillator. Most of the patients with heart failure are prone for arrhythmias and sudden cardiac death due to ventricular tachyarrhythmias. For managing that, additional implantable cardioverter defibrillator or ICD is incorporated in this device, and the combo device is known as CRT-D. In heart failure with reduced ejection fraction and wide QRS with left bundle branch block pattern, there is loss of synchrony in contraction of various regions of the left ventricle. Because of the left bundle branch block, there is delayed activation of left ventricular lateral wall compared to interventricular septum. That causes wastage of systolic effort of the heart. That is where cardiac resynchronization therapy comes in the management of heart failure. In cardiac resynchronization therapy, right atrium is paced first, and after an AV delay, the stimuli to the left ventricle are synchronized in such a way that regions of the left ventricle contract as near normal as possible. That is how synchronization is achieved. The left ventricular pacing lead is usually through posterolateral tributary of coronary sinus. The X-ray of a person with an implanted cardioverter defibrillator. You can see the device here, and there are high voltage leads. This is the high voltage lead which is thicker in the superior vena cava, and another high voltage lead or coil, shocking coil, in the right ventricle. And at the tip there are two pacing electrodes also, that is meant for backup pacing. Whenever you give a shock or any other treatment for a tachyarrhythmia, you should expect bradyarrhythmia following that. There could be bradycardia after the shock, and that will be taken care of by these pacing leads. Backup pacing for bradycardia after a shock. This is the schematic diagram of a CRT-D, cardiac resynchronization therapy with the defibrillator. You can see that in addition to the regular leads for a CRT-P or 3-chamber pacing or heart failure device, additional high voltage shocking coils have been incorporated in the right ventricle and superior vena cava. So this is a combo device combining defibrillator, implantable cardioverter defibrillator, and cardiac resynchronization therapy. Obviously, it will be costlier and the battery capacity needs to be higher, and battery life will be lower if defibrillator shocks are being given in between. Now we will go through a brief pictorial review of cardiac resynchronization therapy implantation. The first step in the cath lab would be to get a subclavian vein injection through a left forearm vein, and this is the subclavian vein seen. We want to see the size of the subclavian vein, which should take 3 leads. The defibrillator leads will be thicker, and you need to know that there are no anomalies. Otherwise, after puncturing the subclavian, you may not reach the implant site. So for that, subclavian vein venogram is the first step during implantation of a cardiac resynchronization therapy. Once the subclavian vein has been identified and punctured, we'll put in a right ventricular screw-in lead to get a right ventricular pacing option at the earliest. That is done under fluoroscopic guidance. This is a fluoroscopy image capture. A decapolar electrophysiology catheter is introduced into the coronary sinus. You can see the 10 poles of the decapolar catheter. This is usually used for electrophysiology studies to find out potentials from different regions of the heart. This is a steerable catheter. From the proximal end, you can turn the catheter tip using the steering mechanism. That's why it is used for cannulation of the coronary sinus. The catheter has to come this way and go into the coronary sinus. The sheath for taking the left ventricular lead is threaded over the decapolar catheter and positioned inside the coronary sinus. When the sheath is deeply seated inside the coronary sinus, the decapolar catheter is taken out. And then the guide wire and left ventricular lead can be taken into the coronary sinus. Here you can see that left ventricular lead is in a posterolateral vein, and beyond that you can see the guide wire. This is a left ventricular pacing lead for cardiac resynchronization therapy. After accurate positioning of the left ventricular lead and checking the pacing thresholds, the guide wire will be removed. And then the third lead, that is the atrial lead, will be introduced and positioned in the right atrial appendage. This has a J-shaped preformed curve to go into the right atrial appendage. Now it is ready for 3-chamber atrioventricular sequential biventricular pacing. Here you can see the CRT device and the 3 leads going through the subclavian vein into the brachiocephalic vein and then into the superior vena cava, later on into the cardiac chambers. Here you can see the position of the leads in toto, that is the atrial J lead, left ventricular lead, right ventricular lead, and also a portion of the CRT device. All these are screen captures from fluoroscopy and not direct X-ray images.